Hello everybody, in this video lecture we will cover chapter 19, cardiovascular physiology. Let's go ahead and begin. So we will talk in this chapter about conductive system of the heart and about cardiac cycle. Cardiac cycle includes all events associated with blood flow through the heart during one complete heartbeat. And cardiac cycle includes electrical events and mechanical events, right? So everything that happens when the blood flows through the heart, when heart beats one time, right? It's called cardiac cycle. Electrical events, depolarization, plateau, repolarization, and refractory period. Some of this terminology should be familiar, like depolarization, repolarization, refractory period. I just want to remind you that your heart is an organ, right? Organ is made of tissues. Tissues are made of cells. Now, so your heart is made of cells. So these electrical events happen inside cells of your heart, right? And as any cell in your body, those myocytes, right, those cells of your heart, they are negatively charged inside and positively charged outside. So there is separation of charges. When we cover nervous system, we already talk about it, right? We mentioned that your cells, right? So if you take a cell, right? So here, any cell doesn't need to be neuron or your myocyte, or cells of your heart, but any cell of your body, those are little batteries because there is separation of charges. It's negatively charged inside and positively charged outside, right? So this cell is polar. And if we measure this, right, if we measure this voltage, it will be like minus 70 millivolts, right? From minus 70 to minus 100 millivolts, right? So this cell is polar. Now, what would be depolarization? Depolarization would be when you moving towards positive, right, inside. So inside became more positive and it became negative outside. So this is our depolarization. So this is depolarization. And repolarization back to negative inside, positive outside, right? So those are electrical events. Plateau is a new phase that is not present in an electrical event of your neurons, right? But for your heart cells, yes. Right, so again, cells are polar. So today we're talking about myocyte, your cardiac muscle cells, right? So the cells are polar, negative charge inside, positive charge outside. Now, when we have inside the cell going towards zero and towards positive charge, this is depolarization, right? And then back to negative inside, repolarization. Okay, so on this graph, it doesn't show us exactly everything that is happening. But this line over here, it's a resting membrane potential. Here we have minus 80 instead of minus 70, but it doesn't really make a big difference, right? So, but minus 80, this is a resting membrane potential, right? And this is where we have positive outside, negative inside. And here we only see sodium potassium pump. But we know the process is more complicated because sodium potassium pump creates a chemical gradient, a high concentration of sodium outside and high concentration of potassium inside. And because of this chemical gradient and because we have leaky channel, right, a potassium leaky channel, so potassium start leaking out, creating electrical gradient, right? Here we only see really like sodium potassium pump that creates chemical gradient, and then because of leaky channels, potassium channels, we have electrical gradient, positive and plus and minus, and this is extracellular fluid, and this is cytoplasm, and it can be measured like -80 for your heart cells, right? Now, then we start moving towards positive inside, right? Because remember this part kind of like intracellular, right? So when we're moving towards zero and positive inside a cell, this is depolarization. And then when we're moving back to resting membrane potential, this will be repolarization. Okay, so now actually if we record those events on the graph, and this will be specifically for cardiac cells, it's gonna look a little bit different compared with neurons. Because if you remember in neurons, we have first of all resting like -70, and then we have depolarization and repolarization. Over here, this is our resting membrane potential, right? Then we have like steep change in the membrane potential. So we're moving towards zero and positive, right? And this is called, of course, depolarization. And then we have like period of time over here. So we don't go straight down to resting potential, right? This is plateau. And plateau is a characteristic for your cardiac cells, right? So we have this plateau, and then we have repolarization back to the resting membrane potential, right? So that's what it says here. Depolarization is due to sodium influx. So sodium in, and because sodium is positively charged, obviously we became less negative inside, right? And it's very fast influx because voltage gated sodium channels, they have this like a positive feedback cycle, right? So some channels open and they cause even more channels to open. So we have very fast sodium influx, right? And this will go up towards, so the voltage goes towards zero and positive, right? This depolarization. Now, what happened here in plateau phase? That is different from neuron. Over here, we have plateau because of calcium, calcium channels that are open and calcium moving inside. So so sodium in, potassium will go out. So over here in 3, potassium will go out. So again, potassium is positively charged. So we're losing potassium, so we're back to negative. But at the same time, over here, at some period of time, calcium start moving in, right? So, and calcium is positively charged, so the cell stays positive inside for prolonged amount of time, right? So calcium influx through slow calcium channels, and this keeps the cells depolarized, right? Because few potassium channels are open, right? So cell stays depolarized longer compared to neurons, right? So action potential then happens slower, right? It's so over here, if you see, we have 300 milliseconds when for, and this is one action potential, right? So, okay, so that's our plateau phase, and then calcium channels inactivating, right? So they closed up, and potassium channel open, potassium efflux, so out of the cell, which bring membrane back to the resting voltage, right? And of course, like, look, sodium in, potassium out, but we need vice versa. We need a lot of sodium out. And right, so that's what sodium potassium pump start working over here, right? And returns our chemical gradient back to normal, to our salty bananas. Sodium outside, high concentration of sodium outside, and high concentration of potassium inside, right? So sodium in, depolarization, calcium in, plateau, potassium out, repolarization, right? So let's repeat it again. Sodium in, depolarization, calcium in, plateau, and potassium out, repolarization. Okay. Now, so for your skeletal muscles to contract, you need to receive signal from your nervous system, right? So your skeletal muscles cannot contract without activation from the nervous system. However, your cardiac muscles, they don't need activation from your nervous system to contract because they have what it's called intrinsic conduction system, and they have those pacemaker cells. So your heart cells, cardiac muscle cells, are capable of autorhythmic contraction, so they can contract on its own. They don't need signal from central nervous system. However, your central nervous system can modulate the contraction. It can either speed up or slow down contraction of your heart, and as a result can increase or decrease your heart rate, cardiac output, and so on, right? So intrinsic cardiac conduction system is a network of non-contractile cells that initiate and distribute impulses to coordinate the depolarization and contraction of the heart. So if you look at the heart as a muscle, right, most of those cells gonna be just regular contractile cells, cardiac muscle cells. But some of them will be cells that their job, their function is not to contract. Their function is to initiate this action potential, initiate electrical impulse, right? And because of this electrical impulse, make contractile cell to do their job, to contract. So two types of cells, contractile cells and non-contractile cells, or autorhythmic cells. And those autorhythmic cells are part of this intrinsic cardiac conduction system, right? Now, how those cells are different? They have unstable resting potential. So like, you know, all cells have resting potential, and we can measure this resting potential, and it's from -70 to -100 millivolts. And let's say your skeletal muscle cells gonna have this resting membrane potential until they get signal from your nervous system, right? So they, skeletal muscles, they have stable resting potential. Those autorhythmic cells, they have unstable resting potential. We call it pacemaker potential, or pre-potentials. And this is because those cells, they have leakage sodium channels. Remember, in a normal cell, we have leak or leakage potassium channels. Here we have sodium channels that allow sodium to move in. Remember, sodium potassium pump always make your cells salty bananas. So lots of sodium out, right? Lots of potassium in, so salty bananas. That's why if you have leakage sodium channels, sodium will move in. So positive charges will move in, so your resting membrane potential will slowly try to go towards zero, right? It became less and less negative. Right now, when it reaches a threshold, now calcium channel open. And then we have influx of calcium, and this will create the action potential. But this is not for all heart cells. This is only for these autorhythmic cells, right? The rest cells will be, similar to your skeletal muscle cells, right? Sodium in, potassium out. But those autorhythmic cells, they will have actually sodium go slowly in. So resting potential is unstable, and then calcium moves in. And this influx of calcium producing this raising phase of the action potential. And so this will be depolarization, and repolarization results from inactivation of calcium channels and opening voltage-gated potassium channels. So how would it look on the graph, right? So again, this is pacemaker potential. And you see how it is, it's never straight line. It's always kind of like raising, right? It always goes up. So why we have this number 1, right? Why we have this line? This is because sodium channels. So sodium moving in, right? And resting membrane potential constantly moving towards zero. And when it reaches threshold over here, right? We have action potential, depolarization. And this is due to calcium influx, right, through the calcium voltage-gated channels, right? So calcium in, so sodium's in, calcium in, and what happened over here in number 3? This is our potassium out, right? So you see, they look very different, but again, I wanna repeat that this graph represents electrical event in a pacemaker cell, right? Autorhythmic cells. Okay. Now, let's look at this intrinsic conduction system first, right? And then we get back. So this is our heart, right? So, so that's a muscle of the heart, right? Myocardium. And most of these cells are what? Cardiac muscle cells. So they have some similarities with skeletal muscles. They cannot contract on its own, right? They need, stimulation, and their job is contraction. But what shown here in yellow, and I don't like this picture very much because students are confused because they put these yellow lines and it's look like nerves. But those are not nerves. Those are autorhythmic cells, right? Those are cells. They also muscle cells, by the way, but their job is not to contract, but to create action potential, to generate this action potential, this impulse, and distribute this impulse through the myocardium. And then the myocardium can contract, right? So those yellow lines over here and these nodes, this is a conduction system of the heart. So the first part over here is called SA node or sinoatrial node, and this is natural pacemaker that generate action potential. Now this action potential, that is electrical impulse, start moving from SA node to AV node. And AV node is atrioventricular node, right? It's between atria and ventricle. And here, when we have some delay of the impulse, like 0.1 second delay. Now from here, electrical impulse moves to the AV bundle, right? So this is called AV, atrioventricular bundle. This bundle connects atria with ventricles, and then we have these bundle branches, right? So right and left bundle branches, and they conduct impulses through this intraventricular septum, right, septum between two ventricles, and then Purkinje fibers that send this impulse through the whole ventricle, through the walls of ventricles, right? So this is the conduction system of the heart. So those cells are autorhythmic cells, those the ones that have unstable resting potential. And so they capable of generate electrical impulses without activation from central nervous system, right? That makes sense? All right, so now if we go back, and here's our defects in the intrinsic conduction system may result in arrhythmias, that is irregular heart rhythm, uncoordinated atrial and ventricular contraction, or fibrillation, that is rapid, irregular contractions, useless for pumping blood. So heart contracts very rapidly and it doesn't have time to relax, so it doesn't really pump blood out. Also, if we have defective SA node, then this result in ectopic focus. If SA node is a normal pacemaker, right? If it's damaged, then AV node take over. And when AV node takes over, so AV node becomes pacemaker. We call it junctional rhythm. And you see it's slower than a normal heart rhythm, because normal heart rhythm about 75 beats per minute, right? Junctional is from 40 to 60, so it's slower. Defective AV node, however, results in what we call a heart block. It can be partial or total heart block. And that means that, well, if AV is defective, we still SA that is working, right? But electrical impulse either cannot pass through AV node, right? Or some impulses are not passed. So we have block between atrial and ventricle conduction system, right? And that means few or no impulses from SA node reaches the ventricles, right? So kind of like if you look here again, so if SA node, pacemaker node is not working, we have junctional rhythms that AV node starts sending these electrical signals. Now, when AV node is not working, because this is the only connection over here between atria and ventricle, right? So we have SA node firing, but some impulses might not move through atria to ventricle, right? That means heart will not contract, or it will contract irregularly. And by the way, when we have SA node as pacemaker, it's called a sinus rhythm. Sinus rhythm or junctional rhythm. Okay, so SA node is a pacemaker and it generates impulses about 75 times per minute. That is sinus rhythm. So that's a normal rhythm of your body. SA node spontaneously generate impulses, right? How fast? 75 times per minute, right? And those cells that make SA node, because SA node, it's a bunch of cells, right? So those cells, they depolarize faster than any other part of myocardium. So because they depolarize faster, right, they faster to generate action potential. AV node, smaller diameter fibers, fewer gap junctions. So here we're talking about cells, right? And because the diameter of fibers is smaller, because we have fewer gap junction, we have delay of the impulses, right? We already mentioned it, 0.1 second. Depolarizes 50 times per minute in absence of SA node input, right? So this one is 75 times per minute. If we have AV node, or if we have SA node that is not functioning, why wouldn't it function? For example, if a patient had a stroke, right? Oh, I'm sorry, heart attack, because stroke is related to your brain. So the patient has either ischemia or heart attack, and some of these cells in SA node are damaged and died, for example, right? So SA node is not functioning. Now AV node takes over, but it's gonna generate 50 times per minute action potential, and it will slow down heart rate. Now, AV bundle, the old name is bundle of His. This is only electrical connection between atria and ventricles. And then we have these AV bundle branches, right and left bundle branches, two pathways in the interventricular septum that carry impulses towards the apex of the heart. And Purkinje fibers complete the pathway into the apex and ventricular walls. Now, AV bundle and Purkinje fibers, they also can generate their own action potential. They also autorhythmic cells, but they would generate only 30 times per minute in the absence of AV node. And of course, that's not enough to sustain life, right? So that's, that wouldn't be enough to have normal perfusion of blood and normal supply of oxygen to patient organ. Right, so I'm just going back over here so you can see what we talked about: SA node, AV node, AV bundle, bundle branches, and Purkinje fibers. So all of them are autorhythmic cells. All of them has this pattern of action potential, right? Unstable resting potential, and they depolarize because of the calcium influx, right? And when we have SA node as a pacemaker, it's a sinus rhythm, and this is the one that 75 beats per minute give you, or 75 times, what does it mean? 75 action potentials per minute. AV node about 50 times per minute, and bundle, AV bundle, bundle branches about 30 times per minute. Now, if you have a patient, let's say if you have a patient and the patient has SA node that is not working, right? Usually they, or damaged, right? So it's not firing anymore. Usually they don't even do anything. They, you know, they just leave it how it is, because AV node will take over, and yes, patient will have a little bit slow heart rate, but still enough for this patient to, you know, continue with his life at a normal pace. However, if this node is not working, AV node, or AV, you know, we have some blockage here in AV bundle, that's more critical situation, really, because you can generate electricity in your atria, but you need your ventricle to contract, right? So when it's heart block, so when AV node is not functioning, that's called heart block. That's more dangerous situation, right? So if neither one, SA node and AV node not firing, they're gonna have pacemakers. They give this patient pacemaker, so they will generate this electrical impulses for this patient's heart. Okay, so that was our conduction system, right? And we said that those autorhythmic cells, they initiate and generate action potential without innervation, without signal from nervous system. However, heartbeat is modified by autonomic nervous system. Cardiac centers are located in the medulla oblongata, right? So even we don't need this ANS to generate impulses, but we do need it to increase or decrease heart rate, right? Because you don't want to have constant heart rate. If you're running, let's say 2 miles, you need your heart rate to increase. If you're sitting on your couch and watching TV, you want to decrease in the heart rate, right? You want to slow down your heart rate. So you do need regulation, and that's a job of ANS. And in the medulla oblongata, there is two centers, cardioacceleratory and cardioinhibitory. Makes sense, right? Cardioacceleratory, that's will, so they both innervate SA node and AV node, right? But cardioacceleratory, it will increase, it will stimulate SA and AV node and heart muscles, right? And it will be through sympathetic neurons, because when do you need to increase your heart rate, right? When you're under stress. And cardioinhibitory center also innervates SA node, AV node, all right? But this will inhibit them through parasympathetic fibers. And those parasympathetic fibers are found in the vagus nerve. Now, electrocardiogram, ECG or EKG, is a composite, so it means like a summary of all the action potential generated by nodal and contractile cells at a given time. So because every single cell of your body, if it's part of the conduction system, right, or it's part of the contraction system, so either generate impulse or contract, anyway, they generate this action potential, right? So when we put all of them together, you can record it on a graph paper, right? And this graph called electrocardiogram. Now you will see three major waves on electrocardiogram: P wave, QRS complex, and T wave. So P wave represent depolarization of SA node, QRS complex represent depolarization of ventricles, and T wave represent repolarization of ventricles. So kind of we have two characteristics over here, two parts of the graph that describe electrical events happen in ventricles, right? QRS and T are both about ventricles. P wave is about the SA node that is in atria, right? Okay. So, you know, here I just show a patient how electrodes are placed, right? You can place them on the arms and on the legs, or instead of putting on arms and legs, you can put over here on the shoulders, right? And then other electrodes are put over here, kind of surrounding the heart. And because it's like, look, imagine there is a heart over here. So you want to look at the heart from above, from below, from left, from right, from angles. So this kind of allow you all this different placement of electrodes, allow you to look at the heart from different angles. And this is called leads, L-E-A-D, leads. Right, so we have 12 different leads that allow you to look at, again, at the electrical activity of the heart at the different degrees, right, different angles. So this is just limb and augmented leads. So they all have like different names, lead number 1, 2, 3, AVF, AVL, AVR, right? So this is from lateral side, this is from right side, this is from below, kind of you're looking at the heart. We are not going into details of all of the leads. What we're gonna take as example is lead number 2. So that's the easiest one to understand. And when you will see the next graphs, this will be all a lead 2. Right, so that's what I told you. So this graph, this is lead 2. And it's represent only electrical events, because electrocardiogram cannot tell you about mechanical events happening in the heart, only about electrical events. So let's look again over here. So electrical impulse move from SA node to AV node, right, to the AV bundle branches, Purkinje fibers, right? And when electrical impulse moving through this conduction system, atria or ventricle, they either depolarize and then repolarize, depolarize, repolarize, and they, of course, they have refractory period. Now, the first wave over here is P wave, right? And this represents atrial depolarization. That means that, well, we initiate impulse over here, but it's moving through all the cells of the atria. So all of the cells of the atria became what? Positive inside, depolarized. So that's a P wave. Now, QRS complex is ventricular depolarization. And then we have T wave, that is ventricular repolarization. What is missing here is atrial repolarization, because kind of repolarization kind of go back to normal, right? So first we depolarize, but then we need to go back to negative inside, right? Positive outside. That's repolarization. So atrial repolarization is missing.
That she's running it through media box.
Oi.
Go ahead. Just go get it. When I'm done here, I know the fucking password. I remember her fucking password. Just go get her phone. She'll trust me with it.
Okay, guys, you need to turn off your microphones.
With her. Just go get it. She'll hand it to you.
I have all 88.
Participants. Okay, please do not turn on your microphones. All right, let me go back. Go. Sure. More. Okay, so I guess I'm recording again, right? Okay. Okay, anyway, so those was our waves, right? And then we have intervals and we have segments. So difference between interval and a segment. Segment is just a flat part of the graph. Interval includes both a flat part and a wave. So if it includes a flat part, like over here, for example. So wave and a flat part and a wave again. So this is QT interval. This is PQ interval because it includes a wave and the segment. And segment only has this flat part on the graph. Okay. Oh, I don't know. Stop share. Hold on a second. Oh, okay. Yeah, just go ahead. Yeah, I will do it. For some reason, I cannot move much. Let me see. I'm just kind of stuck on this slide, trying to figure out what's going on. Let me recording. Okay, so again, over here, what do we have? We have two characteristics of ventricles, right? Ventricle depolarization. What does it mean, ventricle depolarization? Those cells, right, ventricular cells, they became positive inside, right? So there is a change of the charges, right? So inside cells are negative and cell is positive outside, right? But when we have depolarization, ventricular cells, they became positive inside. So this is depolarization. Ventricle repolarization, that is T wave, when we go kind of back to how it's supposed to be, negative inside, repolarization. So we have both characteristics of ventricles, depolarization and repolarization, and we have only depolarization of atria. Now, where is repolarization of atria? Now, it cannot be shown in a graph because it happened during this QRS complex. So it's not shown in a graph. So you cannot see the repolarization of the atria on EKG, right? So that is not just not available information from EKG. Because this is a change, there is a little wave, but it's not seen because of QRS complex. So ventricular depolarization happened at the same time as atrial repolarization. So that's what it is. Okay, so now over here, we can see, and you know, they use this yellow and red color. This is not blood flow. This is electrical impulse, right? And yellow is depolarization, and red is repolarization. So depolarization, we're moving towards 0 and positive voltage, and repolarization, we're moving back to negative resting potential, right? So, so first we have this P wave, and this is our atrial depolarization initiated by SA node, and it's called the P wave. So P wave is both SA node depolarization and atria depolarization, because you cannot really see depolarization of one single node. It's very small structure, right? And it will not be, you know, you will not be able to record it. So this P wave, it's a depolarization of atria that initiated by depolarization of SA node, right? Okay, so that's a P wave. Now we have atrial depolarization complete, right? And we have some delay of the impulse. So we have this flat signal. So no electricity is moving, right? So for a period of time over here, we have no electrical kind of like impulse, a movement of electrical impulse, right? After that, you see how depolarization moving through the AV bundle branches, right over here, and then Purkinje fibers. And this gives us QRS complex. So this is ventricular depolarization. And at the same time, we have, you see, atria became red over here. At the same time, atria repolarization of atria occurs, right? So this is QRS complex. Now, ventricular depolarization is complete, right? So we have this flat part of the diagram. And now we start seeing ventricular repolarization. It begins at the apex, and it causes this T wave. And then ventricular repolarization is complete, flat part of the graph again. So, right, so this is actually one cardiac cycle, and those are electrical events of one cardiac cycle. Because if I go over here, just want to remind you that what is cardiac cycle? It's all event associated with blood flow through the heart during one complete heartbeat. What we're describing now are electrical events, right? So during one heartbeat, those are electrical events that happen, right? So during this time, heart beats one time. However, we hear two sounds because one heartbeat is two sounds. Lump dum, lump dum. That's one heartbeat, but two sounds. Right? So here's some abnormalities. So this is normal sinus rhythm. And the easiest part to see is QRS complex, right? So you can see QRS. So right before gonna be P wave, P, QRS, T, P, QRS, T, P, QRS, T, P, QRS, T, right? And of course we can measure the, amplitude of the QRS complex, duration of those waves, right? So that's all. That's all the characteristic of normal sinus rhythm, right? So they all need to be like in a very narrow limits. Now over here we have junctional rhythm. So what is junctional rhythm again? When SA node is not firing, and instead of SA node, we have AV node that is pacemaker, and you can see we don't have this P wave. We have QRS T, so P wave is missing. And also, if you compare both of them, you can see that we have frequency decreases, right? So it's 40, 60 beats per minute compared with 75 beats per minute. This is second degree heart block. And what's going on over here, if you look again, PQRST, right? So PQRST, and then you have P and QRS is missing. That means we generate impulse in atria, right? But it's not passing to the ventricle. So it skips one, QRS complex. And then it's back to normal, PQRST. And here, look, PQRST, P, no QRS. So that's a second degree block. Some P waves are not conducted through the AV node, hence more P than QRS waves are seen. In this tracing, the ratio of P waves to QRS waves is mostly 2:1. So we have 2 P waves and only 1 QRS. In a normal rhythm, we have 1:1 ratio, 1 P, 1 QRS. This is ventricular fibrillation. This is called F waves. So they are chaotic, irregular, and during fibrillation, heart does not pump blood. Okay, and this is where we have, defibrillator, right? When you watch this movie and they say, okay, I need this electrical shock defibrillator, like, I don't know, 2, 3, go, right? And they, put this electrical impulse to the patient chest. This is what when they do it, when we have ventricular fibrillation. So they stop the heart and they restart, hoping to get a normal sinus rhythm. Okay, so here's some other abnormalities. And again, this is normal. EKG, PQRST. Now you see here T is inverted. This sign of ischemia, right? So low oxygen supply to the heart, or this CT, segment elevation, and this is myocardial infarction. And if you ever go to the, emergency, not emergency, sometimes like you go to the, what it's called, not the emergency room, but okay, anyway, where you go to the hospital and you can hear they talking overhead, code STEMI, STEMI, S-T-E-M-I, STEMI means ST segment elevation, myocardial infarction. So code STEMI means myocardial infarction, and it's ST segment elevation. Right, okay. Okay, now heart sounds. So what do you think? Heart sounds. Are this electrical or mechanical event? This is mechanical event, right? But it happened because of the electrical events. So heart sounds is a part of mechanical event of the cardiac cycle. So one heart sounds, one heartbeat are made of 2 sounds, lub, dub. And we can hear heartbeat because of the valves that are closing. So when valves close, we hear a beat. So first sound occurs when AV valve close, right? And this signifies beginning of systole. Systole is a contraction. And second sound occurs when SL valve close, and this is beginning of, at the beginning of diastole. And heart murmurs is abnormal heart sound, most often indicated of valve problems. So again, now where's AV node and where's SL node? That's kind of part of the anatomy, but very quickly I'm gonna show it to you, just in case you forgot where those, nodes, valves, where those valves are. So if you go over here, yeah, that's not really great picture. Is this a good one? Yeah, let's just look over here. I know those are kind of small, but so heart has 4 chambers, right? 2 atria, right atrium, left atrium, and 2 ventricles, right ventricle, left ventricle. Between atria and ventricle, we have AV valve. easy to remember, right? AV valve. This is the one that you might know as tricuspid and bicuspid valves. Right now, this blood vessel over here, that's a pulmonary trunk. And this that goes like this U-turn, this is aorta. Now, between ventricle and pulmonary trunk, between left ventricle and aorta, we have semilunar valves, right? Or, you know, like pulmonary and aortic valves. They are our semilunar, and this is SL valve, right? So now go back over here. So the first AV valve close, and this is our first sound. And then SL valve close, and this is our second sound, right? Okay, so again, here's, we're talking about cardiac cycle, but now we're talking about mechanical events. And mechanical events includes heartbeat, right? So opening and closing, or closing of the valves. And when they close, we can hear the sound. And it also includes systole or contraction and diastole or relaxation. And remember, there is a systole of atria and systole of ventricles, diastole of atria and diastole of ventricles, right? But mostly when we talk about systolic pressure, diastolic pressure, right? Systole, diastole, we're referring to ventricles. But we do have systole of atria and diastole of atria as well. Okay, so I will go over here and then you guys can read it. So this is one cardiac cycle mechanical event. So it includes 1, 2, 3 stages. First stage is called ventricular filling. The second is ventricular systole, or ventricular filling is actually diastole. So when ventricle is relaxed, right? So ventricular filling, this is diastole, ventricular systole, ventricle contract, and again, diastole, right? So here's mid to late diastole and early diastole. So we have stage 1, 2, and 3, and then we have sub-stages over here, right? So ventricular filling, mid to late diastole. What does it mean? It means that ventricles are relaxed, right? So ventricles are relaxed. First, we have ventricular filling. So it's passively. So blood passively moves from atria to ventricle, ventricular filling, and then atria contraction. So passively, we have about 80% of blood flows from atria to ventricle passively when ventricle is relaxed. And then atria contracts, squeezing the rest 20% of the blood into ventricle, right? So now over here, what do we have? AV valves need to be open, right? Because the blood moves from atria to ventricle. Now, SL, semilunar SL valves need to be closed over here. So it says over here, AV valve open, aortic and pulmonary valve or SL valve, they are closed. So that's ventricular filling. Ventricular filling, atria contraction, together ventricular filling. And remember, ventricle need to be relaxed so the blood can flow in. After that, we have ventricular systole. When ventricle is in systole, atria in diastole, right? So atria relax and ventricle contract. Here we have stage 2A and 2B. Isovolumetric contraction and ventricular ejection. Now, isovolumetric means, iso means same, volume means volume, and metric means some measurement, right? So, look, ventricle contracts, but you do not eject blood yet, right? It's kind of like pre this ejection phase. So it's isovolumetric contraction. And this is the time when all 4 valves are closed. It says closed, why does it says open over here? 2A, because it's 2B already, sorry. Yeah, so that's they're looking at 2B. In 2A, right, what I'm telling you, in 2A, all 4 valves are closed. Now we move, and of course it's way shorter. And then we have ventricular ejection. Ventricle continue to contract. Well, if it's ejection, obviously we need aortic and pulmonary valve to be open, because where we eject this blood into pulmonary trunk and into aorta. So those valves are open. Right, and then we move to early diastole. So ventricle relaxes, and when ventricle relax, we have again all 4 valves that are closed, and it's called isovolumetric relaxation. And then back to ventricular filling. Now also you can see how this related to our EKG, right? So here's the P wave. So atria, so we have depolarization of atria, right? And atria contracts after that. Now we have QRS complex, right? And after QRS complex, what? Ventricle contracts. And then we have T wave over here, and we have ventricle after that relax, right? So, and also you can see first sound and second sound will happen over here in the phase 2A and in the 3. So let's go back and very quickly read about it over here. So here we have ventricular filling take place in mid to late diastole. So ventricle need to be relaxed, right? AV valves are open. 80% of blood passively flows. Then atrial systole, and we have remaining 20% flow. Now in this phase, we have some measurement that is called EDV. EDV is end diastolic volume, because that's a diastole, right? So end diastolic volume, it means how much blood in the ventricle right now, right? After 80% passively flow, 20% because of atrial systole, now that's over, how much blood we have in ventricle, EDV, right? So this is the volume of blood in each ventricle at the end of ventricular diastole. At the end of relaxation of ventricle, how much blood we have, EDV. Then we have ventricular systole. Atrial relax, ventricles begin to contract. Rising ventricular pressure results in closing of AV valves. So if ventricles start to contract and it's closed AV valve. And this is where we can hear this first heart sound, because AV valve closes, not beat. Remember, beat has 2 sounds. So that's our lub, right? And then isovolumetric contraction, all valves are closed. Ejection phase, ventricular pressure exceeds pressure in the large arteries, forcing SL valve open. And in a ventricular systole, at the end of ventricular systole, we have another measure of blood volume, and it's called end systolic volume, or ESV. So how much blood remains in the ventricle, because of course you're not pumping out all 100% of the blood. So you pretty much, you have some blood to begin with, then you pump out some amount of blood and something is still left in the ventricle, right? And then we have isovolumetric relaxation. In the early diastole, ventricle relax, and backflow of blood in aorta and pulmonary trunks close SL valve. And this is where we hear the second heart sound, right? So here, that's how they related. Now, what is cardiac output? It's a volume of blood pumped by each ventricle in 1 minute. Cardiac output abbreviated CO, right? And it equals heart rate multiplied by stroke volume. But stroke volume is the amount of blood pumped by a ventricle with each heartbeat. So each time your heart beats, you pump out stroke volume, right? Now, when you multiply it by the beats per minute, right? you will find a cardiac output, because cardiac output is a volume of blood pumped by your heart in 1 minute. Well, now how much blood you pump with each heartbeat, multiply by 70, whatever heart rate is, this is how much blood is pumped per minute, right? Now stroke volume, SV, equals EDV minus ESV, right? This is your end diastolic volume. This is how much you had inside the ventricles, and this is how much left. So whatever you pump out is the stroke volume, right? That makes sense? Okay. Now, because, okay, cardiac output equals stroke volume multiplied by heart rate, right? So can we regulate cardiac output? Can we increase blood flow to your tissues? Can we decrease blood flow to your tissue? Yes, we can, right? How to regulate the amount of blood flowing to your muscles, for example. We can regulate stroke volume, and we can regulate heart rate. Increase heart rate, increase stroke volume, increase cardiac output, right? So now what factors affect stroke volume? Preload, right? So how much blood returns to the ventricle, contractility, how much blood, how strong your ventricle contract, and afterload, right? The more blood you pump out, right, you increase the stroke volume. So afterload need to be small, preload need to be big, and contractility need to be, so we increase contractility, we increase preload, and we decrease afterload, we increase stroke volume, right? That makes sense? Okay, now factors that increase heart rate, or we can regulate heart rate, right? We can regulate stroke volume, and we can regulate heart rate. And all it will affect cardiac output. Now, factors that increase heart rate are called positive chronotropic factors. And factors that decrease heart rate are called negative chronotropic factors, right? Okay, now we already know that nervous system can regulate it, right? So your nervous system can regulate your heart rate, and it's done by autonomic nervous system. And here we're looking at sympathetic nervous system. So sympathetic nervous system activated by emotional or physical stressors. You know that sympathetic nervous system release norepinephrine. Norepinephrine causes pacemaker cells to fire more rapidly and at the same time increase contractility. So you increase heart rate and you increase the contractility, right? You increase cardiac output and of course blood pressure as a result as well. Now parasympathetic nervous system opposes sympathetic effect. Now, parasympathetic neurons, they release acetylcholine. So acetylcholine, what it does, it's actually hyperpolarizes pacemaker cells by opening potassium channels. So they became even more negative. So it's now you need more sodium influx to create action potential. So the more hyperpolarized you, the harder it is to generate electrical impulse. So when heart is at rest, we call it that heart has a vagal tone. So actually your heart is controlled by parasympathetic nervous system during normal activities. So it's your vagus nerve decrease your heart rate on a daily basis, right? However, of course, sympathetic can override it. Now, atrial reflex is a sympathetic reflex initiated by increase of venous return. So you have more blood returning back to the heart. It stretches atrial walls and it stimulates SA node. It's called vein bridge reflex, or just atrial reflex. And also stimulates atrial stretch receptors, activating sympathetic reflex. Right, so this is what we're talking about here. We're talking about, okay, we have autorhythmic cells, right? But we can regulate your cardiac output, right? We can regulate heart rate, stroke volume, right? So, so we can regulate stroke volume by regulating preload, contractility, afterload. We can regulate heart rate using sympathetic or parasympathetic nervous system. And of course, sympathetic increases, parasympathetic decreases heart rate. Also, heart rate can actually increase because of this atrial reflex, so more blood returns to the heart, right? It will increase heart rate. So overall, over here, this is a whole diagram that shows us how your body can increase cardiac output, right? So we need to increase cardiac output when we exercising, when we running, right? When we stressed out, that's what happened. We increase cardiac output. So to increase cardiac output, we need to increase stroke volume and heart rate, because cardiac output, stroke volume multiplied by heart rate. Now, to increase heart rate, we use what? Sympathetic activity. A parasympathetic, decrease. So if we want to increase cardiac output, we need to increase sympathetic, decrease parasympathetic activity. And this is done by exercise, fight, anxiety. What else can we do to increase stroke volume? Well, we need to increase preload. Preload is increased because of increase of venous return and increased contractility. When you increase contractility, you decrease afterload, right? So less blood left inside ventricles after contraction and systolic volume. And increase venous return and contractility also by exercises, by decreasing heart rate sometimes, right? This allow, even here we can increase heart rate, but when heart rate decreases, this allow heart to relax for longer time when heart rate decreases. Imagine if your heartbeat is 120 beats per minute, your heart doesn't have enough time to relax, so you will have very little preload. So blood just doesn't have time to flow from your blood vessels to the ventricle. All right, and of course, epinephrine, thyroxine, excess calcium, that all increase contractility, and contractility can be increased by sympathetic activity. So just take a minute and look at this diagram and make sense of it. It does make sense when you just need kind of like to spend a little bit time looking at it. Okay, so chemical regulation of heart rate. So over here, we said that your nervous system can regulate your heart rate, right? Nervous system, and chemicals can regulate your heart rate, not only nervous system. What chemicals? Hormones. Epinephrine from adrenal medulla and thyroxine. They both increase heart rate and contractility. And also intra and extracellular ion concentration must be normal for normal heart function. It's very important, concentration of calcium, potassium, sodium, right? Okay, other factors that influence heart rate: age, gender, exercise, body temperature. Older we get, our heart rate goes up actually. So older people, their heart rate increases. Gender, in general, females have higher heart rate than males. Exercise, of course, increase your heart rate. Body temperature, if it goes up, it also increases heart rate. Homeostatic imbalances, tachycardia, abnormally fast heart rate, more than 100 beats per minute. If persistent, may lead to fibrillation. Bradycardia, heart rate slower than 60 beats per minute, may result in grossly inadequate blood circulation and may be desirable result of endurance training, right? Because why would athletes want to slow down their heart rate? That's, if we go back over here, it makes sense. When we slow down the heart rate, we allow more time for ventricle to relax and for ventricular filling, right? And then we increase venous return, we increase preload, and we increase stroke volumes, it will increase cardiac output, right? So that's why. And the last slide cover congestive heart failure. And this is progressive condition where cardiac output is so low that blood circulation is inadequate to meet tissue needs. So very low cardiac output, not enough blood flow to tissue and organs, not enough oxygen, right? So ischemia of tissues. And it's caused by coronary atherosclerosis, persistent high blood pressure, multiple myocardial infarction, or dilated cardiomyopathy. This is when the heart muscle became large but weak, right? So that's the last slide. Okay, that's it for this chapter. Okay, let me just, thank you for watching, and I hope it was helpful.